Good morning, everybody. I'm very happy to introduce Archana ma'am. Recently, I came as an examiner to her institute. Madam is a very cheerful ma'am, and she is heading the Department of Anesthesiology at JSS Medical College, Mysore, and she has been a faculty at many national and state level conferences and had publications on the credit. And she is a AHS certified BLS, ACLS instructor and trained in regional anesthesia and palliative care. And her area interest is difficult airway, pediatric anesthesia, and critical. And such as yours, madam.
Good morning, everybody. Actually, the previous speakers have made my job very easy, to be very frank. They have covered most of it, fluid management, fasting thing, everything. So they have made my job easier. Just I am going to reinforce those things which you have to be doing in your practice. So greetings from from the institute where I work, JSS Medical College and Hospital, Mysore. My today's topic will be enhanced recovery after surgery in pediatric anesthesia. So what is enhanced recovery after surgery? It's a multidisciplinary, evidence-based approach to perioperative care. So it was originally pioneered in Denmark by Professor Henrik Kellet, who is a gastrointestinal surgeon. It was in 1993. It was mostly used for GI surgeries. Then later it got expanded to gynecological and orthopedic surgeries in adults. So it's a clinical pathway which is proposed to improve the outcome and speed of the recovery process. So in 2010, a society for enhanced recovery of after surgery was founded in Sweden. Its mission was to develop perioperative care and to improve recovery through research, audit, education, and implementation of evidence-based practices. This includes a series of interventions which are more effective when implemented together than alone. That is, the sum is greater than doing it in parts. So, how does it do? It's by maintaining a preoperative organ function and reducing the profound stress response which follows surgery. Doing this, we can improve the recovery process. So, anesthesiologists have a crucial role to play in this regard. So, it's a teamwork. As I already said, it's a multidisciplinary team which consists of anesthesiologists, surgeons, physicians, nursing staff, dietitians, physiotherapists. But today's talk, as it is in eras in pediatrics, the more important part of this team will be the parents and the patients. Patients, if the patient can understand, after the age when they are able to understand, they have to be involved in the discussion. So what are the goals of this ERAS protocol? One is to preoperative preparation and rehabilitation of the patients. Next is to minimize the stress response of surgery, avoid iatrogenic problems like postoperative ileus, postoperative nausea, vomiting, postoperative delirium, and next is speedy recovery and return to normal function, and early recognition of abnormal recovery and intervention if necessary. The surgical stress has so much of hormonal and metabolic derangements occurring in the body, which may be endocrine, immunological, hematological. So any tissue injury will release interleukin 6 and tumor necrotic factor both at systemic and local levels, which stimulate the nociceptive afferents via A delta and C fibers of the spinothalamic tract, leading to sympathetic nervous system stimulation. So most of our stress response what is seen during surgery is because of this thing which happens because of the sympathetic nervous system stimulation. So what does it do? On the alpha-1 receptors, they cause peripheral and splanchnic vasoconstriction, glycogenolysis, intestinal smooth muscle relaxation. On the beta-1 cells, it causes increased cardiac contractility, increases heart rate, smooth muscle relaxation, peripheral vasodilatation and bronchodilation. On the renin-angiosystem, it causes conversion of angiotensin 1 to 2, which causes peripheral vasoconstriction and aldosterone release from the adrenal glands. So endocrine effects, there is increased glycogenolysis in the liver and muscle, increased glucose and lactate concentrations, mobilization of free fatty acids. They cause hyperglycemia and peripheral insulin resistance. It stimulates hepatic glycogen synthesis, and their immunomodulatory and anti-inflammatory effects are there. And mineralocorticoid action compounds the sodium and water retention. And with insulin levels do not respond appropriately to the hyperglycemia which occurs here, and catabolism. And sympathetic nervous system inhibits pancreatic beta cell secretion, and the severity of hyperglycemia is proportional to the severity of the insult. So hormonal alterations are also there. There is increased ACTH, cortisol, growth hormone, IGF-1, ADH and glucagon release, and reduced or inappropriately low insulin levels are there. So all this lead to mobilization of substrates like glycogenolysis, skeletal muscle breakdown, acute phase proteins and lipolysis. So, and hematological changes may be hypercoagulability and fibrinolysis. Cytokines lead to leukocytosis and lymphocytosis. Anti-inflammatory cytokines are released, so there is reduced general immunity. So, metabolically, amino acids from protein are broken down, fatty acids are from fat are broken down, mineralocorticoid activity is increased. So, that leads to reduced lean muscle mass, depletion of fat stores and fluid retention. So, as a result, there is increased oxygen demand, increasing risk of ischemia, hypoxemia, splanchnic vasoconstriction, which may impact on healing of anastomosis. And there is exhaustion of energy supplies and loss of lean muscle mass leading to weakness. There may be impaired wound healing and increased risk of infection, hypercoagulability, as I already said, and sodium and water retention. So, why children pose a unique problem for us compared to adults? They are unique physically and they pose psychosocial challenges. There are a diverse range of people from neonates to adolescent, as sir already said. They differ in their physiological presentation. So, individual enhanced recovery after surgery protocols may not be universally translatable in this case because of their diverse age groups. So, ERAS protocols have to be customized according to the age, nutrition, development and the type of surgery in these patients. So, neonates require different guidelines, but ERAS Society has already given a guideline for neonatal protocol that I will be showing you at the end of my talk. The application of ERAS guidelines is the key to reduce hospital length of stay and cost through early mobilization, early feeding and early discharge. So, when it comes to hospital length of stay, most of the pediatric surgeries are outpatient surgeries or minor surgeries where the patient can be discharged the day after surgery. You need not keep them. So, only for few cases where you need to keep them, the reduction of hospital length of stay comes in the picture. So, early mobilization, the role of parents and child psychology is very important in the success of this program. So, next, what are the key principles of this ERAS in pediatrics? One is preoperative education for patients and families, preoperative nutrition, minimizing preoperative fasting, as madam already discussed with you all, and carbohydrate loading up to 2 hours preoperatively, standardized anesthetic and analgesic regimens, and early mobilization. So, preoperatively, information and education has to be provided to families, which will reduce the child's and parents' anxiety surrounding the surgery. If the patient is in an age group who can understand what you are telling, so you can tell them what you are going to do the next day. So, that will reduce their anxiety. So, they will come with you happily. You talk to them a day before surgery, so they will have a rapport with you so that they will easily come with you on the day of surgery. But two small children whom you cannot have a rapport with them, so those children may be a problem. In those patients, you may have to talk to the parents and relieve them of their anxiety and tell them the procedure and how you are going to go ahead. And you can also explain them what may be the problems they may encounter post-operatively. So involving older children and adolescents in the planning process can promote engagement and understanding and establish expectations, which has been shown to improve the quality of their care and aid their post-operative recovery. Optimization of medical condition and nutrition. Malnutrition increases mortality and morbidity. It reduces wound healing and convalescence, thus leading to increased length of hospital stay, increased hospital costs, and reduced quality of life. So malnutrition has to be taken care of. Restrict fasting time and preoperative carbohydrate load. Why we are restricting the fasting time is the prolonged fasting it primes the metabolic states and immune response. It induces a catabolic state. It increases insulin resistance and it reduces intravascular volume. So clear liquids up to 3 ml per kg. Madam has already said it's 1 hour prior to surgery, up to 1 hour prior to surgery. Clear fluids, again, she has already emphasized that it has to be water. Next, preoperative carbohydrate load 2 hours prior to surgery. It reduces postoperative insulin resistance, maintains glycogen reserves, decreases protein breakdown, and improves muscle strength. Again, it can be apple juice, cranberry juice. Apple juice is again without pulp, and Gatorade is a carbohydrate drink which is available in the market, but to the Indian scenario we usually don't prescribe them. So it may be apple juice without pulp or any clear liquids. So what does this preoperative carbohydrate load do? It attenuates postoperative insulin resistance, it reduces nitrogen and protein losses, it preserves skeletal muscle mass, and it reduces preoperative thirst, hunger, and anxiety. See, this is the last thing I want to underline, because most of the kids, if you are not giving them anything, they become very irritable. So because of the thirst and hunger or the anxiety of surgery. So all these are taken care of by giving a carbohydrate load. So next guideline in ERAS is avoiding hyperosmotic mechanical boil preparation. Though that increases the risk of surgical site infection, increased bowel wall edema, increased risk of bowel leak and anastomotic descent. So oral antibiotics, chlorhexidine skin preparation a day before surgery, and thorough chlorhexidine wash before skin incision may be adequate in most of the cases. Only in cases where bowel preparation is important has to be given. Otherwise, that is by itself will cause, it will increase the risk of morbidity. So next, coming to preemptive analgesia with a non-opioid drug like injection paracetamol 10 to 15 milligrams per kg preoperatively. Use of anxiolytics like injection midazolam 0.1 milligram kg for children above 1 year of age, and thromboprophylaxis with gradient compressive stockings for the children of adolescent age group if the surgery is getting prolonged. So preoperative antibiotic prophylaxis is a must. Within or less than 60 minutes of surgical incision will help to control surgical site infection as well as other problems. Conservative transfusion has a protocol according to the age and type of surgery of the child. In neonates, the hemoglobin of more than 9 grams per deciliter is recommended for a healthy more than 1 week of age neonate, and for a neonate where the age is less than 1 week and maybe requires oxygen or patient is on ventilator, then the hemoglobin has to be taken at more than 10 grams per deciliter. So intraoperatively, it has to be a multimodal opioid sparing analgesia has to be given. It's better to have regional analgesia, and use of regular acetaminophen is preferred. As already explained by Madam, perioperative fluid management is very important. Monitor and maintain the perfusion, euvolemia and euglycemia, and prevent and monitor hyponatremia. So intraoperatively, prefer minimally invasive procedures like laparoscopic surgeries wherever possible, and use drugs which have no residual effects and which are short acting. Drugs with less adverse effects to be considered, adverse effects of post-operative ileus, post-operative nausea vomiting, and post-operative delirium. And a multimodal analgesia reduces the opioid requirement, and reducing the use of inhalation, it also helps in reducing the use of inhalation anesthetic agents. So judicious use of fluids. Children are less vulnerable to volume shifts compared to adults. A recent retrospective cohort study of pediatric patients undergoing colonic resection identified an association between high volume intraoperative fluid administration and worsened post-operative outcomes. So avoidance of fluid administration for intraoperative oliguria but not for anuria, and administer fluid to address specific clinical problems, and avoid fluid administration for treatment of an isolated abnormal hemodynamic value. Just don't rely on one thing and give fluids. Prevent intraoperative hypothermia. Again here, as I already discussed, it's a diverse thing. Neonates are more prone for hypothermia. Adolescents are almost like young adults. You need not, small adults, you need not bother much. But smaller children, hypothermia is more common, so you have to take measures to take care see that the patient doesn't go into hypothermia, and the temperature below is not reduced below 36 degrees centigrade. Take preemptive measures like warm fluids, warmers, everything, so that the body temperature doesn't go below. And as much as possible, go for primary anastomosis for uncomplicated intestinal atresia. Post-operatively, nutritional care is very important. Early enteral fluids within 24 to 48 hours. Breast milk is the preferred nutrition. Monitor urinary sodium for neonates with a stoma. And parental involvement becomes very important here. Early hands-on care, purposeful practice, build partnerships and communication. And some literature have shown giving some gums for the patient will improve the bowel movement in the post-operative period. So regional anesthesia is used as an adjunctive during procedures requiring general anesthesia. It decreases intraoperative requirement for intravenous and volatile anesthetic agents. It provides a more rapid awakening and earlier extubation. What happens when you use regional anesthesia? There is afferent neural blockade which attenuates pro-inflammatory and metabolic responses to stress. It reduces insulin resistance. In neonates, major abdominal surgeries, they reduce exposure to drugs that may cause neuronal apoptosis. Regional anesthesia, including peripheral nerve blocks and specifically epidural or combined spinal epidural, has many advantages. Multimodal analgesia. Options for multimodal analgesia include paracetamol, midazolam, gabapentin, dexamethasone, clonidine, dexmedetomidine, and NSAIDs. So all these help in reduction in parenteral opioid requirement, potentially contributing to the faster return of gut motility. So avoidance or removal of the surgical drains and the nasogastric tube as early as possible. And some studies have already shown that children who did not have post-operative NG decompression did have a higher incidence of post-operative vomiting. So you have to be very careful when you think of removing the tubes or putting in the tubes. And next is prophylaxis for post-operative nausea vomiting. Again, it's a multimodal approach where which includes preoperative oral hydration, minimal use of volatile anesthetics and opioids, prophylactic use of antiemetics, and tailored postoperative nausea vomiting therapy. Prevention of postoperative nausea vomiting begins in the preoperative period, as I said already, preoperative oral hydration. And what are the strategies? I already said, because avoidance of volatile anesthetics, nitrous oxide, utilization of propofol for induction and maintenance, regional anesthesia as an adjunct with general anesthesia, multimodal analgesia to minimize intra and postoperative opioids, and adequate hydration. This is a risk score for postoperative nausea vomiting. They have given points: strabismus surgery 1, age more than 3 years, duration more than 30 minutes, history of PONV. So if this score is more than 2, you have to always take preemptive measures to reduce postoperative nausea vomiting. So enteral feeding, the first ERAS protocols in adults challenge the initial dogma of delayed feeling after intestinal surgery to allow anastomosis to heal and reduce nausea vomiting. Despite initial concerns, earlier feeding protocols after GI surgery have consistently demonstrated decreased length of hospital stay and decreased rates of infection. So the same benefits are seen in pediatric patients. So as I said, this is the ERAS guidelines, which is in the on the web from the ERAS Society for the neonates. So they have made the recommendation and the quality of recommendation and the strength of recommendation. So you can go through them. That will help you when you give a neonate, when you anesthetize a neonate. So concluding this, my talk, implementation of ERAS protocols can be very challenging in our country. Routine perioperative practices and the perception of best care can widely vary from institution to institution. ERAS implementation requires a team of motivated health professionals. Application of even a few elements can increase patients' comforts and parental satisfaction. These are my references. Thank you.